great work that they're doing to get all these HIE projects going. So Renee, you might want to sit over here because the mic can't.
Talk a little bit
Oh,
more.
okay.
Yep.
We'll both be close.
Okay, sounds great. Thanks, John.
No problems. Like they say, when your flight's delayed, we're going to make up the time in the air.
That's right.
We'll get through it. We've got Mark Falcone from the team on the line, and he'll do a little bit of a demo coming up here. But just the backdrop to this is to focus in on the IAPD-specific projects. So many of you are familiar with work that CRISP has done in the district through connectivity and some of the current services. Those are related to these projects, but these are really targeted to the projects defined in the IAPD RFA that DHCF released now probably 6 or 7 months ago. So the 5 projects we're going to talk about today, dynamic patient care profile. We're going to talk about why it's dynamic, and that just wasn't a cool name to use. Analytic patient population dashboard, ECQM or clinical quality measurement tool, and Mark on the line is going to dig into the details and actually demonstrate live how that tool works. A specific registry around OB forms, and ambulatory connectivity and support. On the phone is Donna Ramos-Johnson. A critical part of CRISP's work on this is the partnership with DCPCA. If you look at the work breakdown among those 5 projects, each organization is working on all 5 projects together. There's some that DCPCA is more focused on leading and some that CRISP is more focused on, but there's a lot of collaboration among the team to execute against these things. I'm going to breeze through these in a second here just because we're going to actually get into each of the specific projects. And the opportunity for you all is to certainly ask questions about them, press on them a little bit, but also for us to start to solicit thoughts on how we can target these solutions more effectively in the district. So this isn't a one-time opportunity. We're going to hopefully be engaging with you both through this forum and others as we progress here. As Aaron said, for the remainder of the federal fiscal year, which goes through September, not a lot of time between now and then. So getting to a specific and kind of mutual understanding of what we would collectively define as success criteria for this project towards the end of that fall time frame is going to be an important part of this project as well. So feel free to read these details on 22 and 23, but if we push forward, just diving right in. So the fundamental idea here, this term, the unified landing page, is the way that this profile is visualized. And if we kind of step back and think about what the purpose of this was, and you think about health information exchange generally, the ability for a clinician or care manager at the point of care to access information on a patient they're treating to improve treatment and diagnosis, decision-making, and care coordination, kind of that macro view of what HIE is about. This tool is about trying to deliver up really targeted pieces of information that are going to be more helpful in care management. One of our experiences that I think lends itself well to this particular project in Maryland, as an example, has been when we serve up kind of everything the HIE has on a patient, it's not well organized and it's difficult for a clinician to actually navigate through all that information and find something that's relevant to the question or the particular encounter. The intent of this solution, which we're going to show some examples of, was to really key up really specific information. And what the RFA outlined was focusing on one, claims data. The district has, through Medicaid, significant Medicaid claims data within which there's valuable content from a treatment and diagnosis and care management perspective. So for example, pharmacy data, ability to serve up more comprehensive pharmacy data on Medicaid beneficiaries at the point of care. Not kind of in the discharge summary, but here's a small view. This is this person's meds according to the claims data. The other example we're going to get into is starting to tie in data from social service agencies, DHS specifically, around HMIS, or the Homeless Management Information System. And they're going to be exposing an API or an ability for CRISP to make a call about a particular patient and see what programs that patient happens to be in, and if they have a case manager and the contact information for that case manager. So that'd be the second really targeted set of information. And then lastly, focusing on a service that's already live in the district, ENS, the Encounter Notification Service, which is the ability to send a real-time alert to a PCP or a care manager or health plan when their patient or member arrives at the hospital. There's information in that service that'd be really beneficial to an ED clinician. For example, we know that a PCP is subscribing to a given patient and they've provided a phone number, we can get that information to an ED provider that may have no context about who that patient is or who their primary care doctor is, facilitate better care coordination. That's the high-level premise. The way to kind of bring that stuff together, because it's coming from all these different sources, Medicaid claims, the Homeless Management Information System, source of data, an existing E&S source, is through a view that we already have live in Maryland called the Unified Landing Page. And the reason we're going down this path to begin is because of a problem that we hit in Maryland, which was we had all these different solutions, right? We started with the query portal, the ability for a clinician to log into this website and find data on a patient. Then we started offering notifications and they go to a different place. And then we had the clinical quality measurement tool and they go to a different place, and it was just totally unusable. And so we needed some aggregation point to be able to log into one thing and access all of those tools. And that was the concept behind the unified landing page. What you're seeing here on this particular screen is the patient search. So, the basic ability to search for a patient in CRISP across all of those tools. And then, as you'll see on the next slide, make sure you've got the right person. And this view you're seeing here is just an example. So we're going to be developing calls to all those different data sets I mentioned through this tool. What you're seeing here is something that's actually live in Maryland. Maryland's prescription drug monitoring program leverages this approach to access the underlying controlled dangerous substance data. And so it would be a similar view where you pull back patients, you make sure you got the right person. There are scenarios where the link didn't happen, right? That a patient went to hospital A and practice B and hospital C, and we didn't get the link quite right because the demographics of that patient were too different to link. And so we still want to be able to show that data together. And so what this tool allows is to say, hey, these were close matches. Some of the older tools, we just give you our best guess, and you'd miss data sometimes.
What tool do you use for patient matching?
You got it. Initiate, it's an IBM product now, but that's the MPI, probabilistic comparison of patient identities to link together.
One on the API, I was implementing simple API gateways. So our goal is to use this as a hub for various APIs coming out of DCA agencies, other places, or amongst DCA agencies, so that we know where these APIs are and we could also substitute them later. It makes management of them easier. It's very new, but we'd be interested in this is just the kind
That's
of
perfect.
thing
Yeah.
that should run into the API.
Absolutely. That sounds, and we should connect with you sooner rather than later on that. That would be good. Please interrupt as I'm going here. If you want me to drill deeper into something or explain it differently, please do, because we've been kind of immersed in some of this language, and sometimes we forget that we've kind of made some of the language up as we went. So please ask. Some of you have probably seen this, Dr. Freeman, you've seen this a ways back. And this is not meant to be kind of the map of what we're going to build. This was just kind of a visual representation a long time ago that DHCF worked on to think about, how would you visualize this content coming from all these different sources in one place. And so what you see along the top is patient demographics, phone numbers for that patient, who's subscribing on the right-hand side of that view. So within E&S, what entities have said, I've got some relationship and responsibility for this patient, and what's their contact information. As you move down, you start seeing some claims data, and an important question for this project is which claims data would be most clinically relevant. We don't want to just try to pull everything. Is it focusing on 2 things maybe, or 3? Is it meds, diagnoses, and procedures? And I think we need clinical input on what would be most relevant. And it may be different in different settings as well. As you move down, you start to see past encounters. So there's potentially 2 sources of that. There's Medicaid claims that we could use for encounters, and there's also the real-time data we're getting from every hospital that we could use. And so there's some decisions there in terms of how we want to display that. The goal for this in the short time horizon we have is to keep it simple. Sometimes there's a tendency to try to add more and more, but the whole starting point of this was to create a simple user interface with the most relevant data that a clinician would want to know at the point of care, rather than Claudia.
So knowing that you're on a very short timetable and we want to come up with something that's usable, so you'll get input I'm assuming or hoping that whatever we come up with by September, how dynamic is it, that is, how much can change later on? Are there opportunities to add fields, or just become like a static document?
No, not static at all. The tool we're using, for anyone that's kind of got a technical bent to them, so we're using an open source technology called LifeRay. And when we're talking about making these API calls, for example, maybe through the gateway or to HMIS, that's one type of data. If there were 4 other types of data from human service agencies that was relevant, we could call that. If we decided to add a different type of Medicaid data, we could do that. And we can create custom views for different user types. So this role sees this data because it's an ED setting, and we've heard from ED clinicians that these are the 3 things they want to see every time. But in an ambulatory setting, it's potentially different.
So is this only acute care, urgent care type of claims we're talking about, or are we also?
So it's not. The claims data that Medicaid has, and just to talk about the process here right now, you know, we're partnered with DCPCA, and one of their partners, HealthEC, receives claims data today. We're working on what the structure of that extract is, but it's hospital, ambulatory, pharmacy, and then the demographics in an encounter file, an eligibility file.
What does HealthEC do?
So, good question. I'm going to segue to that in just a second, if that's so. For this purpose, for this particular project, and Donna, chime in when you'd like. For this particular project, HealthEC is producing the claims data extract that they've already loaded and cleansed, and it's a great leg up for us to not have to go through that process of trying to load and cleanse Medicaid claims data directly from Medicaid.
And can I share with Erin that was a notable piece of this application that the technical review panel commented on, was particularly given a shorter period of time, there's more confidence that some of what's been promised or envisioned could actually be achieved, given the fact that there's already a ready extract of this data. So just wanted to highlight that. The other thing, and Renee and I talked about this previously, but it is important to remember this is essentially right now in the model a read-only file, right, or web portal. So one of the things that would be interesting to get the committee's feedback on, keeping in mind Scott's point about we got to keep it simple, right, is how could we collect information or evaluate people's interest in actually being able to write back to the patient profile. So just maybe, I don't know when you want to.
Like update it,
or like I happen to notice that I don't think this particular data element coming in is correct. Some of those sorts of things, right? Because we can't hold providers accountable when on the receiving end for the information that's in there, but presumably also want people to be able to catch when the information is wrong. And this is a big challenge in lots of places right now, and we may not be able to, again, to deal with it in the next 6 months.
Yeah.
But whatever we need, we need to be thinking about that issue.
So I think that's a parking lot issue, because if you're going to try to get this out by September.
Yeah, exactly. I think it's as we plot towards September, as Erin said, it's all about scope management while still producing something that is valuable, the whole purpose of this, right? But to your point, recognizing that we're building a flexible platform and that as new ideas and new requirements come in, that we can expand beyond them.
Right, and I think my main point, Claudia, I appreciate that point, is that if we want to design, or if we want to figure out effectively we need to be prepared to capturing information on those needs as we move into this.
So I can already, I've got 300 questions about that, or what that process would look like. And, I'm assuming, well, I don't know, but if this is a web-based platform, people will have access because they are subscribed to CRISP?
They are a participant in CRISP, that's
okay.
right.
And then, so if this becomes something that, people see as useful, then that means there'll be more CRISP subscribers, right? That's the only way.
So yes and no, right? I mean, for example, one of the requirements of My Health GPS program is to be a CRISP subscriber, right? So this is sort of predicated, the first real use of this tool will be for the My Health GPS program, which, helps address the scope issue as well. So just for other folks who, I know Claudia knows this, but for other folks who might not. And so, we're going to be testing some of these questions about access and defining roles and access throughout this process as part of the ambulatory connectivity and support component of this project. So, you guys may have other answers to that, but I think that's one of the things we need to understand.
Yeah, I think there are going to be 300 and 400, 500 questions on this, and trying to manage the scope here. Think about the fact that web-based access would be what we start with, but that, using the FQHC as an example, a lot of the GPS participants that today they access CRISP through eClinicalWorks. And so, doing single sign-on to this tool from eClinicalWorks, we could explore that. Exposing the APIs directly to ECW, we could explore that. So, I think there are inevitably going to be a lot of questions, and hopefully they're kind of opportunistically oriented questions that, wow, we did the right thing in the first 6 months to produce value for a certain set of constituents, and now people want more, and we've got to kind of target that more.
And I think to that point, there will be a sort of formative evaluation throughout this process, right, of these types of questions. So maybe as just to put this out here, if you all around the table and on the phone have the 300 questions that Claudia does, please send us an email, and I suspect what we'll be able to do is bucket those into, groups where we can sort of talk to the CRISP folks and the DCA folks, et cetera, about what's now, what's an area to watch, what are things that are just off the table for the moment, and then we can report that back to the
Right. Yep.
But on that larger issue you've raised of this is in many ways focused on CRISP subscribers, the hospitals pay to subscribe to CRISP.
Correct.
What are the practitioners?
Pardon me?
The practitioners.
They don't pay.
But they're on.
They can they participate. They can participate. So just let's use this. Let's say we've got a practice that's not participating in CRISP and any of the services today. They don't get notifications. They don't use the query solution today. This service goes live, and they either want to use it or they're a key target to use it. They wouldn't be charged anything. We would ask them to sign a participation agreement, which is largely codifying their obligations and our obligations because they're going to have access to PHI. So we're signing a business associate agreement, kind of the basic terms and conditions. And then we'll go train them up, working with Donna's team, and they'd have access. So when we say participant, we largely mean signing the agreement to make sure that there's a set of terms and conditions governed.
So the MFA is not paying to be part of CRISP?
No. The health plans and hospitals pay fees, both in Maryland and the district. Individual practices, even if they're very large, don't.
Anything I wanted to know?
And that's actually one of the reasons I believe that the policy board suggested that in our outreach about HIE, we talked to both the hospital and MFA to get some different perspectives there.
I'm going to keep us moving just for sake of time, if that's all right. We can come back to any of this both now and later. So reporting and analytics. I'm going to break this down at a high level, and there's a ton of examples here in the slides that you can walk through. We're not going to go through all of them, but the key concept here was that both with claims data and information already flowing through the network, you can produce interesting insights for a given practice or FQHC or hospital or someone with care management responsibility for a panel of patients. In Maryland, this work has evolved over the last 6 or 7 years with a very similar claims data set, an all-hospital, all-payer claims data set that they capture. And it's evolved in both a set of static reports, readmission reports, potentially avoidable utilization reports, things like that, and some custom reports that are more unique and that you can interact with as an end user. I want to narrow the time frame I'm looking at, or I want to include different patients, or I want to focus on a specific chronic condition, or I want to look at patients before and after an intervention. And so, our joint proposal with DCPCA was to focus on both of those things, initially putting most of our attention towards the static reports, and this is where Health EC comes into play. And Don, I'll let you speak to this in just a second to describe your relationship with them, but the high level is that there is already Medicaid claims data flowing to Health EC, which we're going to leverage for the care profile purpose, but they've already got loaded up, and they've got a capacity to produce these standardized or static reports. They do this today. And so focusing on 5, 6, 10 reports, and this is where we're going to need input, and starting to produce those for the target constituents of this initiative. That's the nearest term value we can get to relatively quickly. And then the custom reports, as we start to hear from folks, is where we leverage some of the CRISP infrastructure. And we've got a few ideas that we'll show you in a second in terms of things that we think could be valuable that we'll come back to. Donna, before I kind of fire through the examples, do you want to offer any thoughts on the Health DC relationship?
Yeah, I can just, to answer Dr. Freeman's question, I mean, Health DC is a firm that offers a population health management platform that receives input from a variety of sources, but primarily claims data. And in our case, we're also sending clinical data from the EMRs of our connected health centers. We've been working with them for about a year, well, actually more than a year, in sort of configuring the application and working with DHCF to load claims data. We've got 3 years of history of claims data for our health centers loaded into the application, and we've configured a number of reports that allow us to look historically at a number of things. So there's readmission reports. There are a range of things related to a specific patient population. So that's sort of how this effort got started, and in working jointly with CRISP, the notion is to extend the use of that application to other providers who engage in specifically in the MyHealth GPS program and beyond that, as we sort of roll out capabilities and make them more available to providers.
Thanks, Donna.
Mm-hmm.
So if you kind of flip through these slides, we've probably got a dozen slides in here with different images. The intent was to suggest and to show that there's existing capacity to produce some of these standardized reports. What you'll see, both in terms of Health DC, CRISP, a clinical quality tool we're going to go through, some of these things are going to sound similar, and there's going to be some overlapping capacity between different solution providers. We've treated that as a good thing, that we focus vendors in certain areas where we need them to deliver, but we've got alternatives. And we've done that for years at CRISP, where we've got partners in play where we can turn to one partner if we need to or put pressure on the other. And so it's been a successful model for us. A few that I'd point out just as we get beyond the standardized reports, and Donna described those as, readmissions or avoidable utilization targeted to a population, a specific panel. If you go to slide...
and I'm actually just kind of flipping through them so people get kind of that.
If you have the hard copy, and maybe you can go here, Renee, to say 41, just as an example of when we think about something custom. One of the things we've focused on in Maryland is something called a pre-post analysis. And if you take, say, 300 patients that are in a care management program, you send them through the master patient index, so you uniquely identify them, and then you look at claims data before and after an intervention point with a control group, right? So we'd have to work in the control group. You can start to derive some analysis of whether or not that intervention has been impactful. And the first place we did this in Maryland was with a high ER utilizer program at Sinai Hospital. They gave us the enrollment dates and the specific names of the individuals, and you could look at each individual's utilization of ER services, both at the specific hospital but other hospitals over a period of time, both in terms of actual visits, utilization, and charges associated with those visits. And you'd see really interesting things. For some people, it would go down, but then balloon up at the hospital down the street. For some, it went net down, and on aggregate, it went down. And the progression has been to add that control group so you can kind of figure out were there other things going on that might have influenced that outcome. So as we think about custom reports, we're going to bring some ideas like this forward to a range of constituents, including you all, and say, does this sound valuable? Will this be progressive for the programs that are operating in the district?
Do you have the measures that comply with MACRA?
Great question and great segue. This audience is great for segues. So I'm going to turn it over here to Mark. Are you on the line?
Yeah, can you hear me?
I can hear you. So Mark Falcone is with CRISP. He leads CRISP's electronic clinical quality measurement work. He's going to talk about the tool that we'll be deploying. So this is project 3 now. We just went through care profile number 1, analytics and reporting number 2, now we're going to talk about quality reporting. And this tool was initially developed in Maryland, focused on the meaningful use certification measures, which as you progress, as meaningful use 2 for Medicare went into meaningful use 3, it is essentially MIPS, right? And so Mark is going to walk through some details on the quality measures. And what I'll just call out as a thought exercise for all of us as we start here is, those of you that are familiar with measures, and those of you who aren't, there's going to be a little bit of gray area as we talk about the hospital measures and some of the things like readmission analysis, for example, that we'll be doing on the analytics side, and what Mark's about to talk to in terms of clinical quality measures at a provider and practice level and how those are calculated and displayed.
So Mark, I gave you control as the presenter, and so if you'll grab that, and you'll share your screen.
If you'd like to run the slide deck, and then we'll switch over when I'm ready to do the demo, I think that would be easier.
No problem. All right, so there you go.
Great. So before I dive into a quick background on the tool, which we call Caliper, I thought it'd be helpful to do a little bit of a background on clinical quality measures in general, for those in the room that are less familiar. This slide this information is taken directly from CMS's website. I just wanted to show here that there are hundreds of clinical quality measures. There is a subset of those measures that have been published in electronic format. Those measures roll up to, if you look at the bullet points here, specific domains, whether it's they're geared towards health outcomes or clinical process or patient safety. The hundreds of measures all sort of fall into one of these categories, but in simplest terms, quality measures are tools that are to be used by providers to ensure that they're delivering effective, safe, efficient, patient-centered, equitable, and timely care. And CMS, for the past few years, have been leveraging clinical quality measures as a tool to be used by providers when they're reporting their results, whether they're participating in an incentive program like the Meaningful Use Program, or with the current value-based payment programs like we have QPP, whether you're participating as a provider in the MIPS side or an alternative payment model like PCMH or ACO. If we could jump to the next slide, please. So I just wanted to give a few examples of some of the quality measures. These are ones that are published electronically. CMS 138, preventative care and screening of tobacco use. Just to break this measure down, you take your panel of patients that you've seen between for a particular reporting period starting X day and ending on X day. It pulls all the patients that you've seen during that period and assesses those that aren't smokers, that aren't tobacco users, are in your numerator, and those that do use tobacco and yet you as a provider provided cessation counseling, they also fall within your numerator, but those where you missed the opportunity to provide counseling to that patient and they are a known tobacco user would not fall in your numerator. And so this is an effective tool to just assess how you're doing for when you're meeting with patients on an ongoing basis, ensuring that you are asking the question whether they use tobacco, and then if they are, you are providing counseling or giving them help on how to quit. If we could jump to the next slide, please. And so about three or so years ago, CRISP partnered with DHMH here in Maryland because we wanted to have a better understanding of clinical quality measures, how they're being used by the provider community, and more importantly, we wanted to have a better understanding of what are the barriers or challenges associated with calculating clinical quality measures and then ultimately reporting them. And what we found, I tied to maybe 4 specific categories of barriers that providers face. The first and foremost, probably the biggest one, is cost. So what we found is EHR vendors or third-party solutions are offering clinical quality measurement tools, but the cost of purchasing one of those tools can run anywhere between $25,000 to $50,000, which, if you're a small independent practice, that could be well outside your reach. In addition to that, there's a number of experts that are needed to ensure that your coded data in the back end of your EHR is being pulled into that system correctly, so that your measures are calculating and are accurate. And so all of these sort of roll up to costing a lot, and unfortunately, it's not something that a lot of providers can afford. And that is in addition to, if you ultimately want to report your results electronically, most vendors will charge additional costs there as well. The other thing we found was optionality. Some of the vendors were only certified to calculate a minimum set of measures. So using the Meaningful Use program as an example, if your vendor only has 12 quality measures that they offer you, and you have to report 9, and 5 of those measures are irrelevant to your practice, there isn't much you could do. And many providers didn't realize this when they were purchasing their certified EHRs, because they thought they were going to get everything that they needed, but that just wasn't the case. Accuracy of the CQM results is another big one. Working directly with practices across Maryland, I've seen instances where a healthcare organization has not one but 2 different systems to calculate clinical quality measures, but still struggles to get accurate results out of either system. This is a known issue, and CMS is very aware of it, but it is an issue that needs to be addressed. And then accessibility. This was the last thing that we found that seemed to go against logic. Many of the vendors, or I'll say some of the vendors, opted to only give providers access to their results data when it comes time to report those results for whatever program they're participating in. And so that, we felt, deviated from the true spirit of what clinical quality measures are supposed to be and are supposed to do. They're supposed to allow you to monitor a performance over a period of time and allow you the flexibility to look back at, whether it's last week, last month, or last quarter, and just see how you're doing or see how your peers are doing. Some vendors only just give you the results when it's time to report them, and that doesn't give you the opportunity to monitor performance and ensure that you're on the right track. So all of these things rolled up to us recognizing that there was a real opportunity to better serve the provider community, to provide a resource that they can use as a service to ultimately calculate their clinical quality measures and then be in a position to report those results to the various programs that they're participating in. The other key thing that we found when we did this environmental scan was the realization was that if you're doing clinical quality measurement and you're only relying on the data that resides within your EHR's walls, you're ultimately going to find that your CQM results are going to be inaccurate, and that's because patients go and seek treatment elsewhere, whether it's down the road or across the street, and in many cases there is a potential result, a lab result or a screening that is pertinent to clinical quality measurement, but you don't have that information in your EHR and coded value, and as a result, it doesn't get included, and your performance is inaccurate, or the CQM result is inaccurate, and your performance isn't necessarily as high as it could be. And the realization was that if you do quality measurement at the community, at the HIE level, where you're aggregating data across the many healthcare organizations across the community, you have the ability to pull that data on the patient that's pertinent to CQM and include it in the calculations, so all providers get credit for that mammogram or that lab result. And so All the barriers that providers face, in addition to that opportunity to provide a solution that could more accurately calculate clinical quality measures, led us down this pathway to develop the Caliper tool. Caliper stands for CQM-aligned Population Health Reporting. It's designed to do just that, to aggregate data across the community and run calculations. In 2015, we began development on it, and the tool was ultimately certified in December of 2015 for ONC's 2014 edition certification for all CQM criteria. It can accept data in nationally recognized standardized formats in either the CCDA or QRDA Category 1 format. It will parse those files on an ongoing basis, store them in a clinical data repository securely, and make them available to those participating providers to run calculations on later. The other important differentiator about the tool is in the way that we architected it is Caliper can accept custom electronic clinical quality measures, not just the ones that are published and known throughout the industry. So if you have a particular measure that is maybe outside of the norm that needs to be calculated for a particular program that you're trying to support, Caliper has the capability to accept that custom electronic clinical quality measure and run calculations off of your patient data. One other quick thing that I'll add is we're in the process of enhancing this tool to meet 2015 edition certification requirements. There's a number of enhancements that are being made to the tool to allow the flexibility to run calculations setting multiple parameters, whether you want to look at a practice site or a group of practice sites, a TIN or a group of TINs, or specific provider types. You can run calculations that way. It'll also allow you to drill down into those results further if you're interested in slicing the pie differently and looking at patient sex or age range or insurance or problems. That's work that's being done right now to enhance the portal that we're going to show you in a little bit. And we anticipate that that code is going to be deployed summer of 2017, just a few months from now. If we could jump to the next slide. So apologies for this slide. I know you probably can't read it. I know that we're going to be passing out a paper version of this or an electronic version after. We just wanted to give you a snapshot. These are all the electronic clinical quality measures that Caliper has been certified to calculate per 2014 edition certification. I'm not going to go through all of these. Just wanted to provide them to you as a reference that these are where Caliper's current capabilities lie. Now, based on what I said earlier with regards to custom electronic clinical quality measures, we have every opportunity to expand upon this list to better suit the needs of the provider community in DC. If we could jump to the next slide. So this is just a screenshot of the Caliper tool. We will be going through a live demo of this in just a bit. So we can skip past this and go to the next slide. So this is the open-ended question that we're looking for feedback right now. We'd really like to identify which measures are deemed a priority for DC, and what type are they? Are they clinical quality measures? Are they HEDIS or claims-based measures? Or are they hybrid? Do they leverage both clinical and claims data? And then what programs are important? So as per a meeting that we had, a presentation that we did last week, we're now looking at the home health and My Health GPS programs and the measures that are required to be reported for those particular programs. After a cursory glance, we can see that some of them we're already certified to do. Some of them, there's no electronic version of those particular measures, so that will lead us down the pathway of authoring those measures electronically and loading them into Caliper. But this is just an open-ended question at this point. We'd like to get as much feedback as possible as to what's important here in DC so that we can ensure that Caliper can meet the requirements of whatever program or initiative it's meant to support. And I think that's it, Renee, for the slides.
Okay. And actually, here in the room, we were just talking about that maybe we should hold off on the demo at this point just because of the time frame that we have. So thank you for that.
Yeah, that was helpful, Mark.
Okay.
Okay. I'm going to keep us moving. Donna, are you still with us?
Yes, I am.
All right. All right. So the next project, so that was project 3 within IT. 4 is the OB form and web application. I'm going to turn it over to Donna just to describe that DCPCA is leading this initiative. The broader Christian is supporting it. But Donna, maybe I'll let you walk through the project.
Sure. So for those of you who are familiar with the OB assessment and authorization form that is used by providers in the district as part of a process to, number one, capture some initial assessment information upon diagnosis of a pregnancy, and then to also transmit that information to Medicaid, to DHCF, or not to the Medicaid managed care organizations to initiate payment for OB services. What we're doing is we're automating that process or automating that form in 2 ways. One, inside of eClinicalWorks, we're creating a smart form that will capture that information, and we're looking at various ways of doing that. But the intent would be to minimize the amount of additional data capture that's required to complete the form, and to do an extract of the data that's captured for that form so that it gets sent to a new OB registry that will be maintained by the district. A second pathway for those that are not using eClinicalWorks would be a web-based form that will be used to enter the same kind of data, most likely accessible through the unified landing page, so that we can have sort of 2 pathways to collect that information and make it available to the district's registry. One of the things that we're focused on in terms of the OB form capture itself is making sure that data is transmittable. It's through the CCDA to the HIE, and it can be so that it's broadly available to whoever may be seeing that particular patient in the healthcare ecosystem. So that's sort of it in a nutshell. It's we've already initiated some of the development work or the design work around it, and are soliciting input from providers on the best way to introduce the access to the form, both for ECW users in particular, in their workflow and the provider workflow. So.
Thanks, Don. Any questions on that one? That one's pretty straightforward. So.
Why don't you go on the next one, and I'll
Okay.
do that. I know there are some HIE policy board members who have raised a particular question about bidirectional exchange. And
Sure.
I think it would be good just to address that, head on as we move into this process. Again, keeping in mind some of the scope issues of this project, but that clearly is the direction and interest of the board and the community.
Believe it or not, that is a good segue to this. I swear it is, and I'll explain why. So this last project, ambulatory connectivity, it's just at the highest level what every HIE, most HIEs around the country have struggled with. It's harder to do than connecting to a hospital. There aren't as many motivations for an ambulatory practice to spend the money to do it. They don't have the resources. All of those factors that make it challenging to actually engage them as a data sender to the exchange, not just a recipient or a user of the portal. We've had some recent success in Maryland over the last, I'd say, 18 months in driving more connectivity. And when we talk about practice connectivity, there is a base assumption that they've got an electronic health record from which to send clinical data. There are some lower barriers of just getting encounter data, just getting a scheduling feed or an ADT feed to know that a patient was there. You can actually provide some pretty valuable services from that. The ability to say this patient did actually have a post-discharge follow-up visit at a given practice because we saw the encounter data come through. But the real target is to get continuity of care documents or clinical summary documents at the end of an encounter in the same way that a hospital shares data to be used for permitted purposes, a range of permitted purposes, things like treatment, right? That you're not just seeing the hospital data, but you're seeing ambulatory data. But also importantly, feeding into the quality measurement tool. So when we talk about clinical quality measures, while there are claims-based measures, as Mark described, the fundamental premise is you're calculating measures off of clinical data produced during an encounter, and the continuity of care document, the CCD, is the predominant document type we get from which we calculate all the measures that Mark looked at. So this is a big project. It's an important project. It is a project that DCPCA and partners are leading on outreach, ground game, setting up forums to create a larger program around ambulatory connectivity, and on the CRISP side, actually driving the technical connections with the practice, leveraging some of the experience we've had to date. So this is a very, very important part of this project. It's very difficult. We didn't emphasize this during the quality measurement presentation, but that's a hard thing to do. The quality measures are hard for a lot of reasons. One is kind of the fundamental quality of CCDs coming from practices and the level of effort to get them to a good place. Provider trust in the measures themselves when you're calculating them is a big, big barrier to overcome, and it takes a lot of engagement to get there. And so that's what we'll be focused on for ambulatory connectivity. As a segue into bidirectional connections, I think we can think about that broadly, right? And then get specific. On the broad side, we talk about ambulatory connections specifically. We had kind of unidirectional connectivity, sending data to ambulatory providers or allowing them to query one-way street, and now we're focused on making that a two-way street, that they're able to share information through the network to the benefit of an ED provider or a care manager outside of that given practices setting. But then we also start to think about, I think I heard on a previous call, immunization registry or some other registries that may be available, and it being kind of historically, I'm routing my immunizations to this thing, and that's what meaningful use required, but how important is it to get that data right back out so that when you're treating a patient, you understand whether or not they've had a given set of immunizations. That is not tied specifically to these projects, but critical for, I think, the district and for CRISP to support. Barney, it takes me back a little bit to the API gateway you were just describing before and thinking about a more comprehensive approach to how information is exposed from a lot of these registries, so that whether it's CRISP calling it into a view, like the unified landing page, or it's the FQHCs directly getting that data. My understanding is that some of these registries already allow for access. If you're going to their specific website, you can get the data out. But creating those tighter integrations where it actually works for a provider in their workflow, I think is what the part of the objective of some of those bidirectional connections are. I don't know if that was.
One way to do it is to allow a patient to access and have this as their aggregator. They know what, we've got multiple portals.
Right.
Every doctor you go to, you have a portal now. But none of the portals will integrate with each other.
Right.
So the HIE could be a patient portal to be the aggregator, that way you get the information.
Sure.
Whether the person is participating or not.
Yep.
Nice future concept.
Very big picture questions, and then I'll try to follow everything. So we got this big grant that will have all these deliverables by September 30th. I think you ran us through the deliverables.
Right.
Lots of great stuff. So let's say there's something that's developed in Maryland, like the patient population dashboard you showed us. Are we paying so that a new group of
Right,
subscribers?
can folks on the phone hear Barney?
I'll repeat the question.
No.
Okay, I'll repeat the question, Barney, after you.
Sorry about it.
I see where you're going, though, so keep going.
Yeah, so are we getting additional subscribers with the grant to an existing thing, or are we getting new capabilities developed? And my big thing comes back to subscribers, so who, September 30th, who has access to what?
Sure. So two parts. So to repeat the question, Barney's question was, some of these tools have already had some development activity and they exist in Maryland, and so what is the grant funding going towards? And does that then tie to, is it to grow users and subscribers of the tool? And the answer to that is it's a little different for each of the 5 projects. Two very important concepts. One, you can't spend federal dollars twice on the same thing, right? So we have a tracking process to ensure that doesn't happen. But it was very appealing to CMS that the district was going to be able to leverage investments that the federal government had already made. And some of these areas are going to be new features and functions that just don't exist in Maryland today. So the Unified Landing Page is an example. The ability to call DC-specific claims data or the HMIS API doesn't exist in Maryland. There will be development funding going into building that capacity that would be unique to the district. You raise a critical point, and I think is a failure of HAEs, that we get all excited when we go live with something, even when there are no users. And like the real value of the exchange is that it's being used in the community, and people are on a day-to-day basis finding reason to go leverage the solution. The target out of the gate, so we're talking more or less a 6-month time horizon here. The target out of the gates is to get these solutions live and to get a core set of users, and that's still under development. The discussion so far is to really focus on the GPS participants. The 12 GPS participants is probably the priority users. Sorry, you want to describe GPS?
Sure. So unfortunately, Joe Weissel, who's been the architect of this program, working with a number of providers around the community. So this is a large-ish health home program. So health home program care coordination and care coordination for individuals with multiple conditions. And our state plan allows us to offer this. We specified 3 or more chronic conditions is are required to actually be eligible for the program. And so we just concluded the provider application, their call for applications, and got a number of really interesting, innovative proposals. Those folks will really be at the leading edge of our efforts to understand if you have EHR technology and you're enrolled in CRIS and you have demonstrated commitment to aligning your workflow and your care processes with health IT to provide integrated care coordination, and you're willing to go and be accountable through a pay-for-performance program for quality care, those are the folks who enter this program. So they're a really great sort of, I don't want to say test group, but they're a really great sort of set of early adopters to work with this system, and we'll learn a lot by working with them about who the next set of users would be.
But there's not, exactly, and there's not an intent to limit, right? There's some requirements around how the money's spent and focused on Medicaid providers, because it's IEPD money, 90-10 match from the Medicaid program. But, when you think about the district, every hospital takes Medicaid. There's a very broad swath of providers that accept Medicaid, and the threshold's not as high as the Meaningful Use program around, meeting, so it's just if you accept Medicaid. And so, I think creating those phases of rollout and figuring out what the group sizes are will be part of this project.
And, and Scott and Renee and Donna and I certainly talked about this at length. I mean, there's going to be some critical importance to demonstrating the utility of these tools, having some early wins early on, right? It may be the case that not all of these tools are, sort of gangbusters right out of the gate, and that's okay. There's an evolution of understanding how to access and make the best use of this technology that's going to have to occur, right? So, we'll beg your continued feedback on this process, as well as patience, right, in working with the provider community to make sure that these are truly useful tools that support their work. And if over time, right, we find out that one of these is not as useful as we'd like for it to be, we have the opportunity to shift our attention and resources, and that learning process, I think, is going to be a critical piece of our grant work with CMS funding over the next couple of years. Part of the reason, again, that we are putting a lot of emphasis in the strategic planning process, so we're very clear about where it is the district wants to go. We're using a data-driven approach to inform that strategy, and then we continue to bring that information, all that information, back to you all as a policy board for further input and helping kind of nudge and shift our direction. So lots to learn in the next 6 months.
So what is the mechanism for ongoing clinician input into this?
Under development, frankly. One is through the program. So we've been in front last week. There were a few presentations, ongoing presentations where it's a bidirectional discussion with the GPS participants, for example, the 12 GPS participants. Part of the ambulatory connectivity and outreach strategy is to be engaging with providers in the community. Donna's going to be helping us do that with some of her partners as well. But we're going to need more, and I don't think there's ever going to be a place where we feel like we're done with that. I don't think it's a point-in-time process. We definitely need kind of upfront requirements and to refine what we call user stories, a really explicit statement of how these tools will be used by providers, and making sure that we've articulated those statements correctly. But I'd say there's some engagement now, not enough, and it's a known area for improvement.
And one of the things we talked about is you talked about the other grant that was received, and Donna has, we've had conversations with Donna about is there any touch points for those? So there's not like multiple people contacting the practices, not showing kind of this unified approach that would be beneficial to them in the end. Donna, is there anything to say about that side?
No, I mean, I think that, there are now 2 programs that are offering services for providers to assist them in getting connectivity and to assist them through the meaningful use process. So again, I think as Renee said, we want to make sure that there's a cohesive message that's being delivered to providers about the range of services that are available to them. But to Dr. Freeman's point, which is how do we solicit input from providers to help us shape the direction of some of these initiatives. And I think that, we'll make direct contact with providers, and Dr. Freeman, I'll make sure that we include you in a conversation, because there's very specific things around the analytics side of it, and around just how the workflow for the OBR process, and what things would be most beneficial from a delivery standpoint that we can make sure we can do in the short term. So I've made a note that I have folks get in contact with you, and hopefully we can form we've already reached out to some of the folks at the health centers, and to try to formulate some a cadre of providers that can help assist us in getting some things that put together that are very useful.
Thank you.
That's great, Donna. And Ms. Nairn, just real quick, to piggyback on Donna's comment, wanted to emphasize that this TA and outreach contract that we have with VCPCA and Clinovation is actually has 4 option years connected to the base year. So while I gave you some particulars about this initial year, there is a much broader scope of work that has been envisioned for those option years to continue on, both with these tools and others, precisely to ensure that this continuity and ongoing support that we provide for community-based providers is really there over 2020.
So I'll just close with a couple bullets here just on next steps. It feels really tactical here, right? We're getting into the nuts and bolts. So I mentioned the user stories and kind of really explicit requirements. We're in the middle of that right now. Got an all-day session tomorrow on it. Working with DHCF, Donna, and other stakeholders to refine requirements across all of the projects. Getting explicit about the claims data we intend to include in the different projects, and working on actually getting that claims data loaded and available via API. So we're digging in and off to the races here, but setting up the program in such a way that we can course correct as more information comes in.
Terrific. Thank you very much.
I have a question. This is Angela from Unity Healthcare. So I don't know if this is to Scott or Aaron or both of you, but this has been a long-standing question on the policy board. I think this came up when we first started our partnership with CRISP, and that is, are there opportunities for branding the District of Columbia on these types of tools that we're developing? And also, on an ongoing basis, like I guess on governance of CRISP, are there opportunities for people from the District of Columbia to be involved in the greater strategic direction as true partners of CRISP, and not just sort of. I think we're going beyond this sort of vendor relationship, and so I just want to bring this up again.
Thank you.
Sure. So, Angela, sorry, that is a great point. And in fact, I'm going to turn this back to Scott
sure.
I can talk more about this, but CRISP has recently incorporated as an entity within the District of Columbia and is in the process of developing a DC-based board. So, Scott, do you want to add to that?
Sure, yeah. So as Erin just said, we have recognized this point that you're making, Angela, and that Dr. Freeman, you've made and that others have made, that, while there is, I will point out, while there's no Maryland branding on the tools we're talking about, CRISP is, more or less associated with Maryland, right? I think everybody gets that.
CPAR would do that, yeah.
Right, so, and maybe even just to kind of put the other thing on the table, the fact that there are hospitals that participate in both, regions isn't a relevant way to actually represent the district. And so I think accountability to, this group is important, but certainly recognize, no one on our side disagreed with the points that have been made over the years now. And so as part of that, CRISP has really rethought the organizational structure overall. Beyond Maryland and D.C., CRISP also operates in West Virginia. There are about 30 hospitals in West Virginia connected to CRISP. They'll have most of them by the end of the year. And really starting to think about each region having its own corporate structure to operate services locally and its own management team and its own governance process, buying technology from this entity that we kind of collectively call CRISP today, the tool sets that are used. And so in West Virginia, there is the West Virginia Health Information Network, and they buy services from CRISP, and we work exceedingly closely with them, and a lot of the work happens behind the scenes by CRISP staff. In the district, slightly different scenario, but we established, as Erin said, a new corporate entity that will have its own board of directors. For the time being, its management team will be outsourced to the CRISP management team just from an efficiency standpoint. But CRISP is going through a process with partners in the community of identifying potential board members that are DC specific. That's in flight right now, and we can bring more details back to the group as that evolves. But our hope is that this is an important step, not the only step, but a very important step to recognize that discussion.
So could we make that an agenda item for the next meeting?
Sure.
Discussing on the progression with the DC CRISP board at the next policy board meeting? That would be great.
Sure.
Especially since I think the next one's going to be the focus on sustainability. Maybe we can even talk with you all about maybe a bit broader presentation on that.
Sounds good.
Great.
Exciting. But interesting to see whether or not there's a conflict of interest serving on this board and that board.
My question, I'm the guy who runs.
Yeah, I see what you're open to there. Yeah, go ahead.
Okay. 44, it shows chronic condition data in Maryland by county.
Mm-hmm.
At this level, it looks like really interesting public information, and I couldn't figure out anything about a particular patient.
Totally, yeah.
So how does that work in Maryland? What is, say, DHMH allowed to publish? What could, say, RDOH publish?
Yep.
From this, or what information is proprietary?
Sure. So, and maybe I'll add a term, proprietary and, PHI, that a public health officer or kind of broader constituency wouldn't have access to. So the question from Barney is really looking at slide 44 as an example, which is kind of high-level data at a county level. Who would have access to this? What's its value versus more explicit kind of patient-level data?
I mean, I kind of get the patient-level data is the main thing here, and the practitioners are the main users.
Right.
But there are these other users.
Well, there's the public health.
Yeah.
I mean, which is the piece I haven't seen in all the conversations, also the public health.
Yeah, so there's a reason for that. And so to try to answer both of those probably inadequately, because I'm going to do it quickly, is the reason you didn't see public health in this presentation is because this was focused on the 5 IEPD projects. CRISP's broader work with the district absolutely includes public health. That's an area where I think, particularly with this new board that has, more focus on DC objectives and accountability towards those DC objectives, public health should be a critical part of what this infrastructure can do. So all the connections to hospitals, the more connections that will be created through the ambulatory connection efforts that this supports, can feed a public health set of priorities. And beyond public health, there are other things that aren't in here that CRISP can and should support, but it should be at the direction of the leadership and the board.
Well, I think Barney hit on something very important, though. In the district, it's about city services as well. You see these type of clusters of home health, and we know that we need different types of city services there. So it helps plan for resources as well.
Sure.
Yeah, I think that's a great point, and I just want to emphasize that, did initiate some conversations with the DOH folks, particularly about what a future state set of activities could be around surveillance, and particularly looking at some of these issues of, high BMI. Right. And in
So this is new to you. Well, most of it is either
it's different.
self-reported or just collected
Right.
from other sources, but not.
Or surveys, yeah.
But it's not,
Yeah.
it's not generated from actual health records.
Right, and so, in fact, New York has done a lot in this area, and I would just caution, perhaps, that I think this is one of those, I wouldn't call it a parking lot issue, but I think we need to make sure the data flowing into this system is really good before we jump to that next step of thinking about its uses for chronic disease surveillance, which absolutely, I think, is a direction a lot of people would be interested in going. And the district is, even based on New York's experience, the district is in a unique position to do this if we can really get good coverage and feel like we have good surveillance estimates, because our rates of coverage are among the highest in the country, right? Like top 1 or 2, depending on how you count. So since there's so much, insurance coverage, New York has really said that's an important precondition to being able to use these kinds of systems for surveillance. So I think a lot of work to do, but please do know that we're working with DOH and have a lot of interest in seeing, once we can assess the data quality, how it could be used for those types of purposes.
And I think that's spot on in terms of data quality. The only thing I'd add is, so there's going to be a team focused on this stuff that's got to get this done. There's another team that's operating this infrastructure, and things we could support today and just port over from Maryland. I'll just give you a 30-second example to get the wheels turning here, and these are the types of things we'd want to hear from folks. In Maryland, the DHMH collects information on patients that are actively in treatment for HIV, and then assumes those that have fallen out of care. There's about 15,000 patients in Maryland that have fallen out of HIV care and are potentially communicable. They send that list to CRISP, and we send an alert back to the team if they arrive at any participant in the network. And they've reconnected in 1 month with 300 HIV-positive patients that have fallen out of care. No new project work for us. We just loaded the panel, sent the notification. We could do that in a week here. There's policy content there to work through. But that's an example of something like, let's use this infrastructure that exists today to help achieve public health goals.
And I know we're running a little short on time, but maybe are you able to say something briefly about just the surveillance connection with DOH?
Yeah, sure. So we did make some recent progress with the DOH team in terms of, again, leveraging existing tools so that when a communicable disease, for example, does come in and there's been a reportable condition, that they can then log in to CRISP and search for information electronically that may have been produced, say, by a hospital in the district. That's live in Maryland. That's now live here in the district, just I think as of like last week.
Yeah.
So there are the wheels are starting to turn, but there's just so much more. One of the things I'd offer is just to share the checklist of things that have happened with the Department of Health in Maryland and see how many are relevant to the district as a starting point.
Yeah, terrific. Well, on that note, I will simply kind of recap and say, we appreciate both patience and impatience with this process, right? There's this creative tension, as Scott mentioned at the outset, between really wanting to see these tools get into action and be as good and responsive to all the needs in the district as possible. At the same time, we really do need to maintain laser-like focus on getting these tools built and implemented and starting to get feedback on their use in practice and for these various purposes. So